Good morning, everyone. And my name is Dr. Lalit Verma, and we'll be starting this course on macular disorders. I know there is an overdose of some of the disorders, but we'll try to be as crisp as possible so as to spend more time on discussion. And I'm joined by an eminent faculty here, Dr. Raju, Dr. Dinesh Talwar, Anand Rajendran, Dr. Mallika, and Dr. Avnindra Gupta. And we will try to cover very, very common disorders which we have labeled as treatable macular disorders, where we can do something for our patients. You see, macular disorders are one of the most common disorders which we see in our practice. And because of advancements in diagnostic, primarily OCT, a lot of attention is now focused on these disorders. You see, way back, a couple of decades back, angiography was the main modality, but now I think OCT is done much more often, and OCTA is assuming more and more importance. And I pay a lot of attention to OCT because each of the comprehensive ophthalmologists should master this interpretation of the OCT and identify all these layers. Because today, believe me, all retinologists, in fact, all clinicians are dependent on the information provided by the OCT. And interference ho jati hai, beech mein thoda kar doge. And it's very important to show these photographs to the patient, because if you convince a patient that this is how a normal OCT looks and this is how his OCT in that eye looks, because once you show him, he becomes very much compliant to your advice. Because we should not just tell him that you have a CNVM or CSR or whatever. If you show him this is normal OCT and this is your OCT. And I think it's a must for all practices, not important only for retinal practices. It's important for all the practices, even for comprehensive. In fact, at a lot of centers, OCT is a must before cataract surgery also, routine cataract surgery also. Because it has been found by a couple of studies that even in a normal looking retina, 10 to 15% of patients do not have a normal OCT. Whether that has any impact on vision or not, that's immaterial, but normal OCT may not be there in routine cataract surgery also. So importance of gadgets in any case is that clinical diagnosis sometimes may take a back seat and gadgets the front seat, but why not? Because if they aid in the clinical judgment and obviously prognosis also. So this slide I'm very fond of showing, and I want every comprehensive to mug up these 10 layers. As a resident, we keep emphasizing all these 10 layers: disease of inner retina, what is inner retina, what is outer retina, and it's very important because it aids in explanation to the patient. Once we are talking to the patient, it becomes very useful. So because of the advancements in OCT, EDI, SSOCT, the focus is recently shifting from retina to the choroid, and hence you see these newer OCTs have programs where you can see the entire choroid apart from the retina, the choriocapillaries, the satellar layer, the Haller's layer, and even the suprachoroidal space. And hence you see things like pachychoroid spectrum have assumed a lot of importance. Although pachy by definition means thick choroid, but all thick choroid do not form the pachychoroid spectrum. So for it to be included as a pachychoroid spectrum, you have to have atrophy or thinning of RP, and the Sattler's layer and the Haller's layer becomes very, very prominent. That is, but we are learning a lot about pachychoroid spectrum, and it's ever evolving kind of spectrum. And as of now, things which are included in this are central serous, then pachychoroid pigment epitheliopathy, neovasculopathy, PCV. They today all come under the spectrum of pachychoroid. In any case, I'm not going to take much time in introduction because we have a lot of disease to cover. But CSR, which all of us thought that we know in detail, recently has come back because a lot of new things are happening. And our own J. Chiplani from LV Prasad has a lot of interest into this and has reclassified CSR into two major subtypes, simple and complex. And this is the table which I copied from his publication. So with this is small brief intro, we will cover these 4 or 5 diseases, starting with the Csr, Cme by Dr. Raju, and then going on to CNVM by Dr. Dinesh, and then DME current management, and how should we be approaching RVOs, and then surgery, what do we expect in a patient of CNVM and macular hole. So all of them will, I think, share some algorithms and do a lot of cases so that they can impress that this is the way to go in these diseases. So with this, I request Dr. Raju to please upload his presentation and start.
Yeah.
Thank you.
Thank you, sir. Thank you, sir, for giving me an opportunity to share the dais with you. You have been my mentor. Slides. Well, CSR and CME, these are not only the most commonly encountered in our day-to-day practice, but also confused. So there is a lot of confusion between these two entities. So let me start with spotters. Is this a CSR or a CME? This is spotter number 2. By history, how can we get some clues? A patient with a typical CSR may commonly complain of a positive scotoma and micropsia, while patients who may have CME may present slight discomfort and photophobia. So when you ask a history, it's very important to ask pointed questions. If you casually ask, do you use steroid medicines, the patient may not come out with the correct answer. So you need to ask very specific questions. Do you use any skin ointments? Do you use any inhalers? Then they come out with the correct answers. Also, when you're taking a history, assess the patient's personality and look for Cushingoid features. It's very important to know that a lot of drugs cause CSR, especially corticosteroids, and also don't forget sildenafil. The clinical findings include the neurosensory detachment, PEDs, and RPE changes in CSR, while patients with CME, we can see the intraretinal cysts in the foveal region on 90D or a 78D examination. Coming back to this spotter, is this CSR or CME? Well, when we did an indirect ophthalmoscopy, this patient had a detachment that was extending beyond the arcades. And you can see the difference between the attached and the detached retina there, and the patient had a break inferiorly. So this was a patient with a retinal detachment, a shallow retinal detachment, and we need to look for corrugated appearance in these patients. So it's important before we rush doing an OCT to do a good IDO, because differentiating an RD is more important so that we don't lose and do harm to this patient. Coming to the spotter number 2, so whenever you suspect a patient of CSR, always try to have a look at the disc. This patient had an optic disc pit, and this patient, when you do a OCT, you will see the Scheisser's cavity. This is another patient who came with sudden decrease in vision. So how do you go about managing this patient? Would you directly do a OCT, or what else would you do? So most of us would continue and do a OCT in this patient. So what would you do next? This shows a CRS detachment, but also look closely, there is also a choroidal elevation. So in this patient, it's important to do a good slit lamp examination, because this patient had inflammatory cells in the vitreous cavity. And ruling out inflammatory pathology is very important in these patients. So OCT is not the next thing to do. Do a good slit lamp examination and rule out inflammation. And when we went ahead and did an angiography, this patient turned out to have multiple pinpoint leakages suggestive of a posterior scleritis. So this patient would require a steroid treatment. These patients did well with steroid treatment. This is another patient who came with a decrease in vision, and he was previously treated with a presumptive diagnosis of exudative RD by a local specialist. He was given pulse steroids and also immunosuppressives. Because the vision did not improve, he came to us, and when we did the FFA, we could see that he had multiple pooling points in both the eyes. These were actually multiple PEDs. And this has to be correlated with your OCT. And this combination use of FFA and OCT helped us to clinch the diagnosis of bullous CSCR. So all we had to do was to stop his steroids in these patients. So it's very important to look for each and everything in these patients. This is another patient, again confused as CSR. the FFA cleans the diagnosis of idiopathic CNVM in this patient. However, OCT is a very important tool when it comes to monitoring these patients. One can monitor this patient on a serial basis and see not only the reduction in the height of the SRF, but on-face OCT images will show us the reduction in the area of the CSR. Again, another important point is to get the OCT of both the eyes. This patient presented with decrease in vision in one eye, while the other eye showed the PED. This is a recent classification, again classified as the simple, complex, and atypical. This is published in Ophthalmology Retina that Sir was alluding to. They are classified as major criteria and minor criteria. I will not go into the details, but you may have to do both OCT and the choroidal thickness. So increase in choroidal thickness is one of the minor criteria that has been considered in this classification, apart from the typical ink blot appearance on FFA or the smokestack appearance on FFA that we all commonly know. In patients with chronic CSR, you may see the RPE changes and the RPE tracks, and autofluorescence is another tool which you can use to monitor these patients. When it comes to the management, most of us know that CSR patients do well with masterly inactivity. You don't have to do anything, just reassure the patient, look for the risk factors, ask them to avoid smoking if they are smokers, and rule out any drugs that if they are taking. So if the patient is asymptomatic, like if you observe these patients for 4 to 5 months, and if the patient responds, you don't have to do anything. However, if they have recurrent episodes after FFA, if the leak is extrafoveal, we have to just do a focal laser. Most of these patients will do well. If the leak is subfoveal, then with the availability of the subthreshold laser, we may have to consider that. PDT right now is not available, but PDT used to work very well when we were using it before. So this is a patient with extrafoveal leak who did very well post-laser. Coming to the medical management, eplerenone is safe, but it is not superior to placebo in chronic CSR. We need to watch out for hyperkalemia in these patients. Antioxidants, again, do not show any benefits with respect to visual acuity, but they are known to reduce the fluid significantly. The role of NSAIDs in CSR is very less. However, their role in cystoid macular edema is very important, because we see a lot of patients which is related to, CME is related to the inflammatory pathology. So in these patients who present with decrease in vision would be classified as clinical CME, while those patients who are asymptomatic would be considered as angiographic CME. Depending on the duration, the patients who have CME persisting for more than 6 months would be considered as chronic CME. However, a working classification would be post-surgical CME and non-surgical CME. The diagnosis of CME is very easy. We have a typical history and biomicroscopic findings. When you have to manage this patient, we have to answer this question, why this patient has developed a CME. So it could be operation-related causes, or it could be patient-related factors. One has to look for the surgical events like a PCR or a vitreous loss in these patients, and also a retained cortex. And when it comes to patient factors, compliance, most of these patients, we would have given them drops in the postoperative period, but they might not be compliant to the treatment that is there. And we also have to rule out the comorbid conditions. However, it is important to remember that CME can happen after a perfectly done surgery. So in these patients, look carefully for the inflammation that is there, and we need to titrate our treatment based on the inflammation. Now, would you treat these patients based only on clinical findings, or would you want to go ahead and do an OCT? I would suggest always go ahead and do an OCT, because vitreomacular interface abnormalities will be there. This patient, as you can see here, has got a point traction, and if you don't do an OCT in these patients, we are going to miss them. And these patients have to be dealt with surgically. Again, we need to differentiate between diabetic macular edema and pseudophakic macular edema. And when it comes to the management of pseudophakic CME, there are 2 points when it comes to the management. One is the prevention part, that is the prophylaxis. Second is the treatment. So when it comes to prevention, you have to start the treatment before you operate these patients. So it's better to start them beforehand, at least by 1 week before or 3 days before with NSAIDs. And NSAIDs with steroids are said to be better than giving only steroids. This is for the prevention part of it. So to prevent post-surgical CME, use of NSAIDs is recommended with or without steroids. Now, which NSAIDs to use? The ketorolac is supposed to be better as per the evidence because it has got better antechamber and vitreous penetration. However, these two drugs have got better market penetration. As far as managing pseudophakic CME is concerned, there is no standardized treatment. So most of us would follow this step-ladder pattern, start with topical steroids and NSAIDs. Important point is to add an ointment at night time. This is what helps in these patients. And go in a step-ladder pattern. If it doesn't work, then one can consider posterior subtenous injection. And finally, oral steroids. Intravitreal injections or implants can be considered at a later point of time. As far as what you should do, it's better to start both NSAIDs and steroids as a combination as far as the treatment is concerned. Role of anti-VEGF in CME is actually very limited. It should be only reserved for eyes which are unresponsive to conventional treatment and can be considered in patients with infectious etiology where immunosuppressive treatment could be detrimental. As far as CME in retinitis pigmentosa is concerned, oral acetazolamide has the strongest clinical basis and should be the first line of treatment. Dexamethasone implant is showing promising results as per these two recent studies. The take-home message here would be to stratify the patients based on the risks, and we have to tailor-made the management for our patients based on the risks. So one may need to start steroids preoperatively and taper them very slowly if the patient is a uveitic patient with the cataract, and one may need to stop prostaglandin analogs in patients who are having glaucoma. So this is the step ladder pattern that I would like to use in my patients. Thank you very much.
We have our Dr. Nitin Verma here, our guest speaker. Should I please give some comments on any questions from your side to Dr. S. Raju about CME and CSR?
I think the important thing with CME is to have a very high index of suspicion. I think the use of OCT has revolutionized that. I think it's mandatory to also rule out pre-existing macular disorders even before one does cataract surgery. And certainly any reduction in vision or unusual visual symptoms, I think an OCT is important. I think that's really going to be the answer. The treatment is fairly standard, and there is a definite step-ladder pattern that has been suggested, which works very well.
Raju, will you prefer a DEX implant in CME, or you will give a posterior subtenons?
I prefer to give a posterior subtenons.
I think this message should be very clear. If it is in non-resolving cystoid macular edema, then posterior subtenons is the treatment of choice, and it works beautifully. There is a situation like in diabetic patient, we know the incidence of CME is high. So in that also your choice is posterior subtenon, or you combine with the anti-VEGF?
So if there is a component of diabetic macular edema that is there, when we see if the patient has diabetic retinopathy, then I would consider anti-VEGF in these patients.
Coming to CSR, I think CSR is one of the most common encountered macular disease in our practices. And till when do you go for a conservative management, and when do you advise any treatment in cases of central serous retinopathy?
So I would usually wait for up till 3 to 4 months is my waiting time, and most of these patients would settle down by that time, most of my patients. And if they don't settle down, then I would do an angiography at the end of 3 months.
Do you think there is any role of Epiretinal or Epitus? Is there any data available for you or in your patients where you feel Epitus or Epiretinal is helpful?
So in case of acute CSR, I would not use any medical management to begin with. So I usually reserve it for chronic CSR or those patients who are not responded to the treatment or observation for the first 3 months.
Dr. Malika, any comments from your side about Epiretinal?
Yeah, certainly Epiretinal can work in some cases. So CSR is such a heterogeneous disease that in some patients we find recurrences happening, in some we don't, and then we find some cases responding to focal laser and some don't. Then some most respond to PDT, but some don't. And when they don't respond to PDT, sometimes you find they respond to anti-VEGF, and the others they respond to Epiretinal. So we try all these treatments, and now PDT not being available, more dependent on Epiretinal and anti-VEGF as well, apart from focal laser. So yes, some cases do respond to Epiretinal where they did not respond to anything else. Yes, but some don't.
Submacular leaks is one of the gray areas. Previously we had photodynamic therapy, but now we don't have PDT available in our country. So these are patients with pachychoroid disease, and you can use drugs which can penetrate into the choroid. I think alfrepicept and Pagenex or brolucimab is one molecule which I think will work in these conditions of pachychoroid or submacular subfoveal leak. Any comments, Raju, from your side? Any experience?
I have not used anti-VEGF in this set of patients, but probably, as you say, that it may have a role, especially when they have the...
Yeah, I have a lot of experience with anti-VEGF in CSR and excellent results, especially when nothing else works. Even I have cases where PDT has not worked and you get excellent results with anti-VEGF.
See, there is a two subsets of patient. One is a normal CSR and other thing is pachychoroid disease. So if the CSR is not resolving, then always go for an enhanced depth imaging. What Raju showed in his OCT, there is a thing what we call as an enhanced depth imaging, where you measure the thickness of the choroid. For the general ophthalmologist, what is the thickness of choroid? It comes around 287 to 300. So anything above that, above the age of 50, that means it's a pachychoroid disease. So in pachychoroid disease, anti-VEGF is likely to work. We have seen reports where CSR getting resolved with anti-VEGF. So patients of CSR who are not resolving on conventional therapy, you can always do an EDI, label them as in pachychoroid central serous retinopathy, and then you can try. I have been trying brolucimab. I'm finding good results with brolucimab in these kind of patients. With this, any comments from Dr. Malika?
There was the CONTAIN study which compared aflibercept with the observation for chronic CSR, monthly injections with sham versus aflibercept. And 50% of the eyes with aflibercept were completely dry, which they were not resolving earlier. So it helps, and it's because it's a hyperpermeability reduction, choroidal thickness reduction happens, so that's how it works.
So the message is not all CSR,
yeah.
CSR with pachychoroid. CSR, I repeat again, CSR with pachychoroid. So it's before injecting, do the choroidal thickness mapping, and if you are able to label these patients as pachychoroid, then only the benefit will come. Next, we have Dr. Malika Arora, who doesn't need any instruction, a forceful speaker, has organized multiple conferences and is a chief retina consultant at Apollo Hospital, Hyderabad. She will be speaking on approach to retinal vein occlusions. Dr. Malika.
Thank you very much, Dr. Gupta. Is it getting projected, please? Projection. Where's the audio visual? Okay, got it.
It's coming.
So, Retinal vein occlusions, very common disorder. And the major risk factors are the usual risk factors for any vein occlusion: hypertension, diabetes, dyslipidemia, tobacco use, and less commonly homocystinemia, coagulopathies, and inflammation. And they also carry a higher risk of associated systemic cardiovascular and stroke complications. So patients should be made aware of those. The highest risk factor locally in the eye is glaucoma. So in a case of RVO, look at the disc very carefully. It's very easy to miss a glaucomatous disc, and if there is any doubt, do more investigations or refer to a glaucoma specialist. And if glaucoma is diagnosed, then avoid steroid injections for the RVO related macular edema, because that could increase the IOP. Similarly, guide the glaucoma specialist to avoid prostaglandin analogues and the alpha agonists, because they could increase the propensity for macular edema, which is associated with RVO. So this is a very common association which has treatment implications. Now, classification can be central retinal vein occlusion or a superior or inferior hemiretinal vein occlusion, each of which can be ischemic or non-ischemic, and branch retinal vein occlusions, which is a major vein or a macular vein, again with different treatment implications, because a macular vein occlusion will not have neovascularization, whereas a major vein requires every year evaluation for neovascularization. Now, what are the complications with these? We know with RVO the most common is macular edema or ischemia, but also over time neovessels on the disc or elsewhere. But most importantly and most dreadful complication is neovascular glaucoma, seen in CRVO, hemiretinal vein occlusion, and also occasionally in BRVO. And conventionally, we used to say that it happens in the first 3 to 6 months, called the 100-day glaucoma. But since anti-VEGFs have come and we have started using them for the macular edema, we don't see neovascular glaucoma in the first 1 to 2 years. And it only comes up when we stop the anti-VEGF for the macular edema, and patient suddenly comes with a painful blind eye after 2 years or 1.5 years. So the risk increases when we stop anti-VEGFs for macular edema. And even the non-ischemic cases that are initially non-ischemic very often progress to ischemic type. So we should not just say that it's a non-ischemic CRVO, so this will never develop neovascular glaucoma. They still need monitoring. So investigations include fundus photography. As we see here, it can document certain things which OCT does not, such as macular exudates, which resolved after a couple of injections. If we had just seen the OCT and the vision, we would have said that the treatment did not work. But you can see the exudates have resolved. So the patient feels happy that treatment worked. Of course, OCT is very important. It can document not only edema, but any vitreoretinal interface problems. And here showing spontaneous resolution of the traction, which often happens following PRP or even injections. Fluorescein angiography, very important to see the degree of obstruction, extent of capillary non-perfusion. It can even help to diagnose a BRVO in a long-standing case where all the other signs have resolved, and you can see the non-perfusion in that area, new vessels on the elsewhere or disc. But most importantly, fluorescein can show leakage from at the macula, which will guide the macular laser, which OCT angiography cannot do. Importantly, when there is some media haze from vitreous hemorrhage or asteroids, fluorescein can pick up the new vessels on the retina or disc or non-perfusion, which you cannot see clinically. So this is another indication for fluorescein angiography. And sometimes you can even pick up new vessels on the iris, which you did not suspect. The OCT angio is non-invasive and can show new vessels as well as FAZ non-perfusion, but the limitations are that it cannot show the leakage for macular laser in macular edema, and it cannot go into the periphery and mid-peripheral areas to show those new vessels compared to fluorescein angiography. Now, treatment is the first line is anti-VEGF injections, and early treatment is important. These studies have shown that even a 2-month delay in starting treatment reduces the number of eyes that will gain by 15 lines from 70% to 40% approximately. So just a 2-month delay can affect the visual prognosis. A recent study, the SCORE 2 study comparing bevacizumab and aflibercept every month for 6 months for RVO, found that the visual results are similar for the 2 drugs. But if you see the anatomic results, complete resolution happens in almost 54% of aflibercept group and in only about 30% of bevacizumab group. So the anatomic results are superior with aflibercept. And then they found that non-responders, bevacizumab non-responders can be switched to aflibercept with good response. Another study, the LEVO study comparing the 3 anti-VEGFs, found that fewer injections are required when we use aflibercept compared with ranibizumab, and there is a greater proportion of patients with thinner macula using aflibercept compared to ranibizumab. Then this was a switch study, the Newton study, to see that if patients require very frequent injections every 4 weeks, does it help to switch them to aflibercept? And they found that switching to aflibercept, you could increase the treatment interval from 5.4 weeks to 9 weeks, almost double, an average increase of a month, with additional improvement in vision as well as CRT. Steroids are indicated in RVO, despite the relative contraindication because of glaucoma. It is indicated when there are contraindications to anti-VEGFs. Avoid steroids in glaucoma, or if there is a history of infection or an immunocompromised patient, or if there is a large PC opening, scleral fixated IOL, where it can allow the migration into the anterior chamber, which is an emergency and can cause corneal decompensation. So what's the role of laser in RVO? In BRVO patients, it is indicated for macular edema. In CRVO patients, there is no role for macular edema, but it is indicated for neovascular glaucoma and neovascularization of the iris. Now, follow-up evaluation for RVO patients is very important. They have to have undilated slit lamp biomicroscopy and gonioscopy for iris and angle new vessels, a close examination of the disc for glaucoma and NVD, and then all RVO patients have to be seen annually, and peripheral examination annually for new vessels and proliferation, and very importantly also for fellow eye involvement every year, because very often they become bilateral and they are silent in the initial stages. What's the time left now? I'm not... You can continue. Carry on? Okay, so this is to show a patient of CRVO with some hemorrhage, pre-retinal hemorrhage, even at presentation. We did an angio which did not show any new vessels, but because of the hemorrhage, we still do laser and ranibizumab injection, despite which it progressed and had NVD. So we added laser, despite which it went into neovascular glaucoma. This is just to highlight that a patient of CRVO or HRVO has to be kept under very close vigilance for neovascularization of the iris and glaucoma. Bilaterality is very common as shown here, and it could be asymptomatic initially, so we have to look for bilateral RVOs. In the young, usually they are relatively asymptomatic, usually idiopathic inflammation, though there could be secondary to these TB, syphilis, HIV, sarcoid, SLE, and blood dyscrasias could be a cause, so look for leukemia, do a hemogram, oral contraceptive pills in ladies, and sildenafil in males, and now we are seeing even post-COVID infection and post-COVID vaccine. Generally less symptomatic with good visual prognosis, and systemic steroids can be used when nothing else is found, or even intravitreal anti-VEGF if there is significant edema. This is post-COVID vaccine. I had a couple of cases, very young patients, no comorbidities. This is 3rd day post-Covishield 2nd dose. And she had CRVO with inferotemporal BRVO, which resolved with oral steroids and anticoagulants without any further intervention. This is a young male, 11 days post-Sputnik vaccine and BRVO, which improved with steroids and anticoagulants, but required ranibizumab for complete resolution of the edema. And how we can correlate it was from injection of the COVID vaccine is the very high COVID antibodies, 3,000 almost, where just more than 50 is positive. Thank you.
Thank you. Thank you, ma'am. We know CRVO and branch vein occlusions are very recalcitrant edemas. It melts on anti-VEGF, but the rebound is very fast. The moment the effect of anti-VEGF goes off, the rebound edema comes very fast. So how do you counsel your patients in these type of disease?
just like diabetic macular edema, we have to tell them that this is a chronic disease and the occlusion is not going to open now. We cannot reverse the occlusion which has happened. So we are only treating a symptom of the disease. So we do need to continue injections, and we don't know how many may be required. But possibly after 1 or 2 years, the number of injections may go down. So this is how we counsel. It is a long-term treatment.
Dr. Nitin, your view?
Yeah, sort of in addition to that, patients often ask, how long am I going to go? And we use a treat and extend pattern in Australia, and we normally find that at the end of about 3 months, when you've taken them up to 3 months intervals between injections, you get 2 groups of patients. Half of them can go to a sort of watch and treat or PR and this thing, and half of them will still remain on regular injections, although may not be at 4 weekly. But I must say that the most dangerous time is when you start weaning these patients off the anti-VEGF, because that's when any neovascularization comes up, because with anti-VEGF you're suppressing them. And I feel that perhaps we have not given fluorescein angiography in these patients enough importance, because we don't do enough of that anymore. We always are treating the macular edema rather than treating the eye. So I implore you to don't forget in patients that you think might need it, which are most of them, do a fluorescein angiogram. It's going to give you so much information and it'll almost tell you which way the patient is going to go. The other thing is there's a group in Perth run, Ian McAllister and company, who have been working on chorioretinal anastomosis in selected patients. We're using a high-powered laser. They create an anastomosis between the retinal vessels and the choroidal vessels so that there's a bypass of the block, and you almost have a total resolution of the central retinal vein occlusion.
So, what's your recommendation when we should do a fluorescein angiography? Whether we should do right at the onset, or like what Dr. Malika said, it's an 100-day glaucoma. So should we do fluorescein angiography somewhere between 2 to 3 months, or should we do right at the onset? What's your, Dr. Malika and Dr. Nitin, what's your, when should be the timing of fluorescein angiography in branch vein occlusions and central retinal vein occlusion?
I would say it depends on the case. If you have enough suspicion at any point that it might be a proliferative retinopathy, that's the time we do it. So usually that suspicion is not there at the first visit. It will only start later, and there are maybe too many hemorrhages initially even. So, so I think it's never at presentation. It's probably down the line when there is a suspicion.
Dr. Nitin, your views?
I think a good time, just remember that when you're giving anti-VEGF agents, you're going to suppress any new vessels, and so the angiogram is only going to show you capillary dropout, non-perfusion, but not new vascularization. A good time to do it is when you're weaning off the anti-VEGFs, and perhaps when you're looking at, when they've reached their 3-month mark, and you're saying, well, should I leave this patient alone or not? You'll be surprised how many patients you'll pick up with, the need for panretinal photocoagulation or sectoral photocoagulation once you do a fluorescein angiogram. So I said, as long as they're covered with anti-VEGF and nothing else is happening, you're pretty safe. But the moment you start weaning off, that's the time to start thinking about it. So I'd say around the 10 to 12 week mark, when you reach that stage and wondering whether I can let this patient go on for longer.
In fact, I would say that if they are on anti-VEGF, you'll get a false negative FFA result, because the anti-VEGF would close the new vessels and you may not even pick them up.
Yep.
So will you prefer to treat areas of capillary non-perfusion if there are extensive, because in central retinal vein occlusion, you won't get a neovascularization at the disc or elsewhere?
So, see, if even with extensive non-perfusion, if we are anyway treating the macular edema, then it's probably not necessary to do any laser. But if we have stopped treating the macular edema, and as I showed a case, even though there was no new vessels, but it looked bad. So yeah, do a mild scatter and keep under very close observation, yes.
One thing important while doing a fluorescein angiography in retinal vein occlusion, especially in central retinal vein occlusion, you should do a wide field angiography, or you should try to look in the equatorial region, because ischemia is not central, it's a peripheral ischemia. So you need to laser the peripheral retina, not the central retina. So it's important to ask, if you are doing a fluorescein angiography, please ask the patient to look in all directions so that you can catch hold of the peripheral retina, not the central retina. With this, I'll request Dr. Nitin Verma to speak on screening of diabetic retinopathy in timers list. Dr. Nitin Verma is a presidential guest. He comes from Australia, from the region of down south Australia. He's the president of RANSCO and has published various papers in number of journals, and he'll be speaking about screening of diabetic retinopathy.
Well, thank you, and thank you for inviting me to talk about. I promise I won't show you an OCT and I won't show you fluorescein angiography, but I really talk about the challenges of setting up a diabetic retinopathy screening program in Timor-Leste and or East Timor. And you might ask, where is East Timor? Now my thing's not moving forward, so I try once again. We are stuck. All right. Oh, here we go. Okay, we'll start again. That's right. So Timor-Leste is near the northern tip of Australia. It's between Australia and Indonesia, and it's a country which is very small, only 1.2 million people. Its capital is Dili, not New Delhi, but Dili, and it has mainly people who are Catholics, and I'll tell you why that's important. Timor-Leste was ruled for 475 years by the Portuguese, then 25 years by the Indonesians, and it's only recently that they became independent after a referendum. And during this referendum, the country was completely destroyed, and then the United Nations came in and so on. So this is important because where we start from is a post-conflict country where every facility, be it governmental, non-governmental, was razed to the ground. So it's like ground zero. And we started the program in the year 2000, so that was 22 years ago. And the first 4 years were spent on concentrating on cataracts and uncorrected refractive errors and whatever was left behind after the referendum. And then we worked from 2005 onwards on the rebuilding phase, which included infrastructure and so on. So what you're seeing here are pictures of their National Eye Center, and how work carries on in between. Here you see some of the registrars or some of the trainees within the center. And also this is supported by outreach in 13 districts where the eye program has now permeated. So again, that's the spread of the eye program. One of the highlights of working in East Timor was the ability to start a training program there at the diploma level. And you see here a very colorful convocation ceremony. But all this is fine. What has the impact of the program been for, for the past 10 years? So the prevalence of blindness has come down from 7.7 to 2.8%, and that sort of says it all. But that has been concentrating on cataracts and uncorrected refractive errors, which is the way these RABs work. Timor-Leste today is very vibrant. It's a bit like what Bali used to be 20 years ago. The demographics are changing. You get people living longer. And along with that has come the problem of diabetes. Now, a number of studies, especially in the early days, have shown that the prevalence of diabetes is around the 4.6% mark. A hospital-based study found that patients who were not diagnosed as diabetics coming to the hospital, that many of them actually had advanced disease. So much so there was no facility to do anything about these patients, and many of them had to be sent overseas for treatment. So it was a situation where most people would present with one eye lost, the other eye with proliferative eye disease. And in fact, the eye care nurses and the eye care workers didn't think of diabetes as a thing to worry about. I mean, if you didn't have a cataract, you didn't have a problem. So you can see that the problem is more than just screening, because the primary system was weak, the tertiary system was weak. There was no way you could do anything for a patient with diabetes or diabetic eye disease, and things were on things were on, they were changing. The more and more diabetes coming in, we weren't able to do anything for it. So much so that all the physicians thought, what's the point of even referring them to the eye people, because nothing can be done. So it was a one-way street. You had a problem, and they didn't, the physicians wouldn't refer the patients on to this thing, because the results of treatment were nothing like the treatment of cataracts. However, things have changed now, and we have been able to establish a vitreoretinal service in the capital, in Delhi. We can handle almost all parts or all stages of the journey, so that we are now really ready to be able to do something about people with diabetic eye disease in the country itself. Also, healthcare is nationalized and all treatment for people is free. 1,000 doctors trained in Cuba have come back to Timor-Leste and have been posted to all parts of the country, so that they've gone down to the village level, and 94% of the Timorese population is now on a national database, so that we really know what's going on, and we can integrate with primary care. So as I said, 94% of households are there, and what you see here is a photograph of a district health center. And I think now is the time, which is a couple of years ago, for us to start screening, because we now have facilities to diagnose diabetes using the HbA1c machines and using the models that have been working in Bombay, and Dr. Natarajan was very kindly allowed us to use these videos and give us a lead with some of the partners supporting us in this. We decided to go with the Remedio camera, which was even smaller, and allow us to reach the periphery where these patients are. Here's the camera itself and the back of the telephone on which all images come. Here's the camera working. It's a very light camera. It's easy to transport and gives reasonable results. So what we have now is we've been through the learning curve, and the company has been very good in sort of helping things out from a distance. So remote troubleshooting is possible, but the teaching and training continues. Here are examples of some photographs, maybe not as good as the ones shown earlier, but they certainly give us enough workable images. The database, and of course some challenges remain because the internet is very slow and we can't upload to the cloud, and they said it's AI enabled, we really don't need it. So we sort of continue working on those issues, and also work on the awareness program. That is the weakness, or that's the weak point of the program itself. We need to pass a message on saying diabetes causes blindness and we can do something for it. Just these two lines. But all this is good, because if we don't engage with the government, and it's a democracy, so parties come, parties go, and the priorities could be different. So I had to work out, how do we future-proof this program? So I suggested to the Prime Minister and to the Health Minister, saying, why don't we make a 30-year program? These 5-year programs are no good. So after much discussion, we launched the 2050 National Eye Health Program in Timor. So that's one of the few countries in the world that's thinking that far ahead, so that any political party that comes, eye care, diabetic screening is all embedded in the national budget. So not only that, the training of ophthalmologists is all set up, the training of optometrists is all set up, integration with primary eye care takes place, new health centers have been opened, or surgical centers have been opened, and really the whole process is now complete. It's all about the patient's journey. You dare not screen for something if you can't do something about it in the end. And so by 2025, we'd have a higher diagnostic rate for diabetic screening, and by 2030, hopefully, it'll be even better. We use every opportunity, such as World Sight Day and so on, to be able to push this one message about diabetes causing blindness and diabetic blindness. If caught in time, we can do something about it. Health education is important. And now we come to this fact that 94 or 95% of Timorese are Catholics. We have not used, and we don't use in many parts of the world, the religious institutions. If the priest on Sunday Mass, where most Timorese go, says diabetes causes blindness and something can be done by these eye doctors, I think it's a very powerful message, and we've been employing that. The other thing is to use politicians. What you see here is the gentleman with a hat on is a Nobel laureate from 1996, Dr. Ramos Horta, and the other gentleman, not the one in the center, but on the other side, is the head of the WHO mission. And he's been a keen supporter and a patron of the program, and now he's the new president of East Timor. And I tell him, he says, Nitin, what do you want me to do? I said, pass these two lines. So this is the total eye health task force in Timor, in this photograph. That's all we have for 1.2 million people, and they can't do this screening alone. The only way a good screening program can work is not with the technology alone, but also involvement of the whole community, the politicians, the government, and the religious institutions. Thank you.
Thank you, sir. Thank you very much for that talk on screening. As far as the Indian scenario is concerned, we do face the same challenges in the villages, and definitely the phone on fundus cameras have been of excellent use when it comes to finding out these cases as whether they have diabetic retinopathy or no retinopathy. Yep. And referring those patients who have diabetic retinopathy to the ophthalmologist would definitely be very helpful.
Yes, I think the important thing is to realize what you're screening for. You're basically, all you're doing is separating the normals from the not normals. I wouldn't call them abnormal, but not normals. And then you've got to deal with the people with findings at a different level, rather than just trying to quantify and say 3 microaneurysms and 4 cotton wool spots. That's not the aim of screening, especially not in countries like this.
Yeah, thank you, sir. Any comments? No, thank you, sir. We go on to the next talk by Dr. Avninder Gupta, again a very senior retina specialist from Delhi, and he'll be speaking to us on surgical macular disorders, especially the vitreomacular interface abnormalities, the epiretinal membranes, and the macular hole. Well, we sets up his presentation. Like it's very important for all general ophthalmologists here that epiretinal membranes and macular holes sometimes can be associated with, yeah.
First of all, I'd like to thank Dr. Lalit Verma for giving me this topic and be in his instruction course. What I'll be talking about, two very common macular disorders, epiretinal membrane and macular holes. Coming to epiretinal membranes, it was first described by Ivanov in 1865. 2% of the patient aged 50 years and 20% of the patient by 70 years will suffer with epiretinal membrane. Bilateral involvement can occur in 10 to 20% of patients. In a very last study, that is Beaver Dam Eye study, which was an OCT-based study which suggested the prevalence of epiretinal membrane as 34.1%. In 2016, preferred practice guidelines for epiretinal membrane over a period of 5 years, 29% of the ERM progressed, 26% regressed, and 39% remained stable. So the important message here is that only 1/3 of the patient will require surgery, Rest 70% of the patient will not require surgery. So whenever you diagnose a case of epiretinal membrane, don't just advise surgery, because until unless we document that there is a serial deterioration of vision and metamorphosia, we are not going to take these patients for surgery. Usually epiretinal membrane is idiopathic. It can occur after RD surgery, non-proliferative retinal vascular disorders, ocular inflammatory disease, proliferative retinopathies, vitreous hemorrhage, trauma, and after cryopexy and photocoagulation. Patients comes with a complaint of reduced vision. 5% have vision of 660. Usually patients complains they have tedha mera dikh raha hai, or the line what they are seeing, it's tilted, and in medical terminology we call it as a metamorphosia. On signs, what you see here is an whitish sheen. That's why we also call as a cellophane retinopathy. There is a tortuosity or straightening of these vessels. You can see these vessels are straightened, and these are the diagnostic signs. In advanced stages, you can see stria, intraretinal hemorrhages, cystic changes in macula, pseudo holes, and PVD in 75% of cases. OCT is the best tool to diagnose epiretinal membrane. Now we don't do any fluorescein angiography to diagnose epiretinal membranes. Usually epiretinal membrane is asymptomatic. If the patient has good vision, no treatment is required. But if the patients are symptomatic, that means the vision is less than 624. I have written a rough guideline. Patient can come with a complaint of metamorphosia at 612 vision also. Then you advise pars plana vitrectomy with ERM removal. This is one case of epiretinal membrane. You can see there is a large epiretinal membrane here, and OCT shows a loss of foveal contour with a membrane. So we took this patient for surgery, and once you clear all the vitreous, you have to create an edge of the membrane, and the instrument what we use to create an edge is a 25 gauge MVR. This is a 25 gauge MVR. We are also loosening the membrane, because many times by doing this maneuver we can find how sticky the membrane is. Once the edge of the membrane is created, you go inside with an Eckhart forceps. It's important, two important thing while you are peeling the membrane. One, you don't have to put anterior posterior, you don't have to pull like this. You have to peel it tangentially, like what you do in a capsular access. So your movement should be tangential, and you should be able to peel the membrane like this. Second thing, don't keep on pulling the membrane from the tip, because from the tip, if you keep on pulling the membrane, then it can break. Like in this case, it broke, and we are not able to peel this part of the membrane. So we had to create another edge of this membrane with a diamond dusted, and then remove the remnant membrane. And whole of the membrane comes as a sheet. These are the post-operative picture. You can see the foveal contour is still not returned. It takes somewhere around 4 to 5 months or till 8 months for the foveal contour to return. This is one of the patient post VR surgery, and you can see a peripheral laser, and there is an epiretinal membrane here. So we have done a fluid air exchange, and because the membrane visualization is not good, so under air we use a reti blue dye to stain the membrane. Once it is stained, then you can see we can create an edge with the help of an MVR blade, and this is the most crucial step, creating an edge. Once you have created an edge, you then can peel the membrane. But the pressure should be gentle. You cannot pull the membrane, just you are pulling, because if you pull the membrane hard, you can create multiple breaks. So I'm lucky to get whole of the membrane in one go, and it's a pretty big membrane, and this patient also improved with good vision. Improvement in visual acuity occurs by 2 lines in 74% of cases. No improvement in visual acuity in 24% of cases. Better results were seen in idiopathic epiretinal membrane. There is a controversy whether to peel internal limiting membrane with epiretinal membrane. Liu et al. Performed a meta-analysis of ERM surgery with and without ILM peeling. Patient who underwent ILM peeling had better visual acuity at 12 months. By 18 months, no significant difference in both the groups. Microperimetry showed better results in non-ILM peeling groups. Previously, I used to peel, but with multiple studies available, I have stopped peeling internal limiting membrane in cases of idiopathic macular holes. Prognostic factor, preoperative visual acuity, CME, are bad prognostic factors. Preoperative integrity, the most important thing what you have to look before advising is preoperative integrity of ellipsoid zone on OCT. The ellipsoid zone is good, then the patient will recover with good visual acuity. You also need to see the parallelism. More parallel the retinal layers are, better the postoperative visual results. Complication can be vitreous hemorrhage, peripheral retinal breaks, and in postoperative period you can have retinal detachment, infections, and recurrence is one of the things what you have to keep in mind, and you also need to counsel your patients because 5% of the patient can land up with recurrence of epiretinal membrane. Coming to the macular hole is a defect of foveal retina involving its full thickness from the internal limiting membrane to the outer segment of photoreceptors. The most common cause of macular hole is idiopathic. It can occur because of trauma and high myopia. Stages are 1A, 1B, where you see donut-shaped yellow ring, and at this stage only we are able to diagnose at 1A on clinical examination that the macular hole is developing. Full thickness macular hole less than 400 microns is stage 2. Any macular hole above 400 microns is stage 3, and association with posterior vitreous detachment is stage 4. OCT is a diagnostic tool and also helps in staging of macular hole. It also helps to prognosticate the patient and calculate various indices like macular hole for MHI, DHI, THI, and MHA. All these factors helps to predict how much, whether the macular hole will close or not, and prognosticate your patients. This is one of the patient. You can see the vitreous is attached to the macular hole. So this is stage 3 macular hole. There is a total PVD here with macular hole. This is a stage 4 macular hole. There are two kinds of closures after macular hole surgery. One is type 1 closure, like this patient I operated. You can see there is an return of foveal contour and all the 3 layers of external limiting membrane IS-OS junction are intact. This is a type 1 closure. There is a type 2 closure also. This we call as a type 2 closure, where the macular hole does not closes, but the edema goes off, and this is called as type 2 closure. This is one of very large macular holes, and you can see we operated this patient, and this patient returned with 636 vision. Treatment is spontaneous once the macular hole is very small. The ideal treatment is surgical, and we do an pars plana vitrectomy with macular ILM peeling. This is my first video. What you do a pars plana vitrectomy. It's basically a chromatic vitrectomy, and we induce a posterior vitreous detachment, and then the ILM is peeled. Here, once we stain this patient with BBG, you see this area has stained and this area has not stained. So the area which is not stained, there is also an epiretinal membrane within macular hole. So first you have to peel this epiretinal membrane, then only you can remove the internal limiting membrane. So an epiretinal membrane is peeled, and then we restain this patient with BBG dye, and I initiate and ILM peel, And since the macular hole is small, I'll peel across the macula and remove this internal limiting membrane. If the macular hole is large, like in this case, then we generally prefer to do an inverted technique. And in this patient, what you can see, we have done a injected tricot. PVD is induced. And you can see here the vice ring coming out. Once the PVD is induced, the staining is done with the BBG dye, and I generally initiate my ILM peel with the help of an ILM, with the help of a diamond dusted membrane scratcher, and once the edge of the membrane is created, I go for an cabbage-like peel, or many call it as an flower petal appearance. So first petal is created. You don't have to cross the macular hole. Then the second petal is created, and actually what happens, you stuff the ILM with stuff the macular hole with ILM, and the contact with the vitreous cavity is gone. So the closure rate becomes higher in these kind of patients. Once this inverted flap is created, the ILM is enlarged and the flap is trimmed. The important thing, whenever you are trimming the flap, keep the suction low at 50, because if you have an higher suction, you can pull the flap out. And this is end of the surgery. The third case, can I show or can I? The third case, what I'll be showing you is a failed macular hole. This patient I have operated, and you can see on OCT is somewhere around 1800 microns. And we went ahead and stained. You can see there is no ILM at the posterior pole. So we have created a flap of ILM nasal to the disc, and then the PFCL is injected, because you cannot hold the flap with the forceps and stuff into the macula. This flap is generally, you can see this ILM flap here. This flap is dragged with the help of an diamond dusted and brought into the center, and the flap is put into the macula. And then I go ahead and simultaneously what I do, I remove the PFCL and put and with other hand under chandelier illumination I put viscoelastic, so that the flap does not get dislodged because of the turbulence of the Constellation machine. And then, because it's a pretty large macular hole, so I create an macular detachment with the help of an 40 gauge needle, and you can see this detachment and the fluid coming out here. The second detachment is also created. A fluid air exchange is done, and this is the post-operative picture, vision improving to 624. So to conclude, advancement in instrumentation has made macular surgery the most sought after surgery. Prone position required for only 3 to 4 days. Results of macular hole surgery is between 90 to 97%, and visual acuity gains are 3 to 4 lines. Thank you very much for your kind attention.
Thank you, Dr. Avninder Gupta sir, for excellent videos. One question that I would ask is, in patients with vitreomacular interface abnormalities, when would you advise a patient for surgery? Because that is the crucial decision one needs to do. And which patients would you select, and when would you initiate this discussion for surgery?
The most important thing, patient should come with the complaints. Like macular hole, yes, macular hole, if the patient usually comes with a complaint of distortion in vision, epiretinal membrane also patient comes with distortions in vision. If the patient complains that my vision is deteriorating and I have a problem, I'll take up the patients for surgery.
So it's a very important take-home message here is the patient should earn his surgery, and only if the patient is symptomatic, we should try to advise him for surgery. With that, I would go on to the next speaker. It's my privilege to introduce Dr. Dinesh Telva sir, my mentor and teacher. He requires no introduction, an astute clinician, and nobody can analyze clinical studies like he does. Over to you, Dr. Dinesh Telva sir, for a talk on CNVM.
Thank you, Dr. Raju. Now, we now come to the last talk of the day, which is on age-related macular degeneration, exudative and exudative type. This is my financial disclosure. Let's start with a case. This is a patient who presented with an occult CNVM with SRF and was treated with PR and ranibizumab, was requiring injections every 6 weeks and was therefore shifted to aflibercept, hoping that we would need less injections. With aflibercept, we were able to bring him to 10-week injections. We tried twice to increase the duration to 12 weeks each time recurrence occurred. So finally, we realized that this patient can only be extended up to 10 weeks with aflibercept. This is a second patient who we started with aflibercept as the initial treatment, and you can see that every 4 to 6 weeks after the loading dose, the patient was requiring injections. So sometimes aflibercept also may not respond to the initial loading doses, and in these cases, then the patient is maintained as a stable lesion on treat and extend to the maximum that we can. So this patient was maintained on 6 weekly injections. This is a third patient who was followed up for 6 years, initially started with ranibizumab, was not responding well, was shifted to Eylea, who did not respond, went back to ranibizumab, and finally was then shifted to Eylea in the end again. And when the second time when he was shifted to Eylea, we were able to extend the duration from initial 4 weeks to 8 weeks, but then he regressed to 6 weeks, again improved slowly to 10 weeks, and finally to 16 weeks. So this 16-week extension, it's important to remember, does not reach in one straight line. There are ups and downs, it's a zigzag course, and you should not lose heart if that happens. The other important thing is that after you've reached 16-weekly extension, and you've been able to maintain that twice in a lesion which is dry, you can actually possibly consider stopping treatment and only following up this patient. This is another patient where 12-weekly extensions were, 12-weekly treat and extend was continuing, and despite that, you can see this large RPE detachment developed, and we had to bring him back to 8-weekly treat and extend, 8-weekly injections of Eylea. How do we approach an individual patient? So the usual approach should be you give 3 injections. You could be giving bevacizumab, ranibizumab, or aflibercept, whatever you use. Assess at month 3. If the lesion is dry, you have 2 approaches. You can either take him to a treat and extend approach, where you extend the intervals between the injections from by 2 weeks or by 4 weeks up to a maximum of 12 weeks if you're using ranibizumab, or 16 weeks if you're using aflibercept. Alternatively, you can maintain this patient on a PRN treatment, which is cheaper, at least for our patients. So let's see, you have a patient, 3 months he's dry, after 3 injections he's dry. Now follow this up for another 3 months. If he stays dry for another 3 months, now you can increase the interval between his follow-ups. He's not getting any treatment, but his interval between the follow-ups can increase progressively to 6 weeks, 8 weeks, 10 weeks, to a maximum of 12 weekly. 12-weekly follow-up in ARMD, exudative ARMD patients will continue more or less like a lifelong follow-up because they can get a recurrence anytime. On the other hand, if the patient gets a recurrence during this period, he gets an injection of anti-VEGF and continues his monitoring on a 4-weekly basis. Patients who are requiring injections more than 8 weekly, if they were on ranibizumab, try shifting to aflibercept. This is the second group of patients. They don't get dry after 3 months. There's still some fluid. But over the next 3 months, you see that the fluid is neither increasing nor decreasing. It's become stable. The vision is stable. These patients can then be considered for a treat and extend regime. You can increase the extension from, again, by 2 weeks till you come to 12 weeks with ranibizumab or 16 weeks with aflibercept. The important thing is that today we are giving a lot of patients initial loading doses of aflibercept. So if you're giving an initial loading dose of aflibercept and the patient did not become dry after 3 injections, then you can consider trying a treat and extend regime for them and seeing what is the maximum you are able to achieve. If you're not able to get greater than 8-week extension, you may even go back to ranibizumab. Now, this is the reason for this is because I believe that in Asian patients, we've seen much more geographic atrophy in patients who are on aflibercept. So if possible, if the choice is between aflibercept and ranibizumab with the same interval, I would prefer to give ranibizumab. So this is what it is. If you gave 3 injections of aflibercept, patient became dry, you can continue this patient on a treat and extend ranibizumab, and if you can extend that to 8 weeks, 10 weeks, 12 weeks, continue on that. On the other hand, if you're not able to do this extension, you will need to go back to aflibercept and maintain on aflibercept. The third situation can be that even on aflibercept, the patient keeps on requiring an injection every 7-8 weeks. These patients would need to be given a trial of brolucizumab. The point is, if you need aflibercept and ranibizumab both 4 to 6 weekly, then it's better to be on ranibizumab than to be on aflibercept. So basically, we want to have the patient on as long a follow-up as possible. What about patients who have not responded to Eylea? Now, this is a patient who was on month after month of Eylea, was not responding, and we decided to switch this patient to brolucizumab. And he responded very well with the resolution, in fact, within a week of the RPE detachment and the SRF. 1 month later, I did not want to repeat brolucizumab because there were reports coming in of more reaction being reported in patients who were getting brolucizumab on a monthly basis. So we gave him an aflibercept at that point to increase this gap. And the patient maintained 3 months after that, and he's now got another injection. On the other hand, this was a patient who was, again, no response to aflibercept, but intraretinal cysts, just not responding, was finally given a brolucizumab, did not get as great a response, did not respond till 1 week, but by 4 weeks, there was a decrease in these cysts, and we again covered up with Eylea before we gave the next injection 4 weeks later. Even in this 4 weeks, the patient got an increase in the intraretinal cysts. So how do you decide when to switch? To my mind, if the frequency of injections with ranibizumab is every 7 weeks or less, I would consider shifting these patients to aflibercept. If the patient is on aflibercept and is requiring an injection every 7 weeks or so, I would again consider giving an injection of brolucizumab. In a patient who's stable, not dry, is requiring monthly ranibizumab, that's not good enough, shift to aflibercept. And if the patient is stable on aflibercept, but is requiring even 6 weekly injections, consider a switch to brolucizumab. However, after telling all this, what becomes critical is how important is the injection you give. And I was amazed by this study, which had a long-term follow-up of 3 different drugs, ranibizumab, aflibercept, and bevacizumab, and found no difference in the visual outcomes or the number of injections between the agents used. The OCT showed decreased fluid, from the initial to follow-up visit, whether it was subretinal or intraretinal, more or less the same, no difference between the agents used. What did make a difference was the more the number of injections given, the more the time the injections were continued, the better the visual outcome. So ladies and gentlemen, please, if your patient cannot afford aflibercept, don't say, I can't treat this patient. Continue with what you have. It is more important to continue the treatment rather than make sure that you have the most expensive drug which is available. And you may still be able to maintain the vision for a large number of your patients. This was a study in which they used only ranibizumab, and at a fixed interval of 4 to 8 weeks, they maintained over 7 years pretty great results, better than 20/40 vision in around half the patients, with more than 2/3 of the patients getting 6/18 vision or so. So ladies and gentlemen, it is possible, the last slide, it's possible to maintain these results if you continue the treatment long enough. The basic principles to keep in mind: there is no tolerance for fluid. Intraretinal fluid is not tolerated unless it's completely unresponsive. Subretinal fluid of up to 100 micron you may tolerate if it is stable and not responding further. You don't have to run after sub-RP fluid. It does not go away with ranibizumab or even aflibercept. But any increase in fluid must be treated. And the most important thing is, in active disease, follow-up every 4 weeks is critical. Ultimately, your results depend on following up the patient intensively and giving the injection when required. With this aggressive treatment, making sure you treat patients with any loss of vision, any new fluid, any new macular hemorrhage, or any subjective evidence of fluid in your mind, you are able to maintain vision for the majority of your patients. Ladies and gentlemen, eternal vigil is the price that we pay for maintaining vision in patients with CNVM. Thank you very much, ladies and gentlemen.
One comment from Dr. Nitin Verma, and then we'll close the session.
Yeah, no, I think I was very pleased to see that Avastin or bevacizumab is still on the horizon, because I personally use a lot of it for things that are not covered by government subsidies. So, but I think the lesson that we've learned from COVID is when patients haven't been able to come for treatment, and then after 3 months or 4 months or 6 months, they come back and say, well, I haven't had a treatment for 6 months, so am I cured? And I think the important thing, as you've highlighted, Dinesh, is the fact that you are never cured, and that some injections are better than no injections, and as soon as you can get back to your treatment regimen before you couldn't come or because of COVID, the better you are, because you don't know when a CNVM is going to reactivate.
Yeah, and that is why the counseling I do for my patients with ARMD, exudative ARMD is, look, you're going to get these injections for your life. Don't forget to take them, and if I cop it, take it from someone else, but continue to take your treatment.
Thank you, Dr. Dinesh. With this, I'd like to thank Dr. Lalit Verma, Dr. Raju, our guest, Dr. Nitin Verma, Dr. Dinesh, for giving us good lucid lectures, and above all, the guests and the spectators for coming here and giving us time for this instruction course. Thank you very much.
Thank you.